and welcome to this Ask the Experts session. My name is Dr. Matt Giannetti, and I'm an allergist immunologist at Brigham and Women's Hospital in Boston, Massachusetts. I'm also the Associate Director of the BWH Mastocytosis Center. In a recent program entitled Managing Nonadvanced Systemic Mastocytosis, we offered learners the opportunity to ask questions, clinical questions that came up after the talk. Today, I will be providing some answers to those questions that were submitted. Thank you for your time. Yeah, this is a great question. So there's not a lot of data for this, but what I can do is walk you through my own clinical practice. So first off, I would say avapritinib is FDA approved at 25 milligrams daily. So this generally is the recommended starting dose for avapritinib. I would also say that during the initial clinical trial that led to approval, the Pioneer study, doses of 25, 50, and 100 milligrams were studied. So all of these can be appropriate doses for ISM, but generally the discussion or the correct path is to start at 25 and increase as clinically needed due to lack of response, insufficient symptom control, etc. The second part of the question is also very good. Absolutely, one of the major purposes of avapritinib is to decrease associated medication, so the patient is taking, less pills on a daily basis. My clinical practice is to start avapritinib in addition to everything else first. And once the patient has been on for several months, 2, 3, 4 months, and they're doing clinically better, then I have a discussion about which medications we would like to wean and start weaning medications one by one. So yes, I do use it also as a tool to decrease medication burden. Yeah, so this is a good question. The question generally is, do we need to check VAF or variant allele fraction of D816V regularly? And how do we use that to make medical decisions regarding tyrosine kinase inhibitors and maybe mastocytosis more generally? So I do assess it regularly, most importantly prior to therapy. So if somebody is going to be put on a targeted therapy such as avapritinib, or other targeted tyrosine kinase inhibitors, it's mandatory, I would argue, that they should have a D816V variant allele fraction prior to that. Routine assessments, I don't always do. I think if feasible, depending on finances, insurance, clinic workflow, et cetera, I would like to do it once annually. And it's particularly important for those who are on tyrosine kinase inhibitors. Of course, these medications are anti-D816V medications. So by measuring the variant allele fraction, you should see kind of a nice decline over time. An increase in variant allele fraction probably should prompt some clinical suspicion. If the patient is doing clinically well, I'm not sure that I would make any decisions solely based on that. But what it does do is make me think about, well, what's going on in this patient? Maybe we repeat a tryptase. If there's a major change, maybe they need another bone marrow biopsy. So it should be used as a tool in combination with our other tools for measuring mastocytosis. So absolutely, hereditary alpha tryptasemia is in fact the most common cause for an elevated baseline serum tryptase. So 100% of the time when somebody has an elevated tryptase, that should be within the differential diagnosis. I would also say at low tryptases, it should be the primary consideration in the differential diagnosis. We do have some data showing cutoff points where clonal mast cell disorders are more likely based on tryptase genotypes. The quick and dirty cutoff that I use in my mind, at least clinically, is around 30 to 35 nanograms per milliliter of tryptase. So specifically, if the tryptase is less than that, generally I think alpha tryptasemia is more likely. When it's greater than that, greater than 35 or so, it's much more likely you have a clonal mast cell disorder or an atypical alpha tryptasemia genotype. So all of this needs to be taken in conjunction. And even more importantly, clinical symptoms can skew one way or another. So somebody with a very impressive history of hypotensive syncope, that to me speaks more to a clonal mast cell disorder. So again, tryptase is important, but the whole picture of the patient, including symptoms, response to medications, et cetera, also need to be taken into account. I am by training an immunologist, so I'm going to have some significant biases here. But I would say that for the non-advanced mastocytosis patients, it really should be an allergist immunologist. Again, I'm a practicing allergist immunologist, so I'm biased. But I would say a couple of points in favor of my argument. So first, the mast cell is our cell, right? So in our clinic, we see allergic rhinitis, we see chronic spontaneous urticaria, we see allergic asthma. The common theme between all of these disorders is that they're caused by activation of the mast cell. So mastocytosis is really just kind of an extension of that. Not only do we know the cell, we're also quite familiar with therapies targeting mast cell, whether it's oral antihistamines, H2 antihistamines, montelukast, omalizumab, et cetera. So I think immunologists are very familiar with this spectrum of disease, and we're generally better at managing this type of disease. On the flip side, I would say in patients who have more advanced systemic mastocytosis, particularly with cytopenias or where there's discussion of bone marrow transplant or more significant cytoreductive chemotherapy, that tends to be more in the domain of the oncologists. So a teamwork approach is very important here. And then finally, I would say primary care physicians really should be involved kind of throughout, right? So they're going to be the quarterback for the patient, kind of the most common point of contact. So it's really important that even if you're primarily managing the disease, you're in close contact with the primary care physician. Thank you for your time today. I hope you found this information helpful. Please subscribe to Exchange CME's YouTube channel and check back regularly for future updates on systemic mastocytosis. Thank you.